Good morning and welcome to all of you who have come here today. Thank you for coming. And thank you to also our online audience. Dr. Anna is an Associate Professor of Medicine. She's also trained in hospital medicine in Canada. And she's going to take us through a diagnostic study. What is a diagnostic study? And using the Casp checklist. So over to Anna.
Good morning, everyone. So the last month in CU, we had gone through core grade, which is about how we develop guidelines. So this month, we're actually looking at diagnostic studies. So the first one is just a basic, simple diagnostic study. So we're sort of going back to the basics after last month's everything. So this is a critical appraisal of a diagnostic study using the Casp checklist. So before we start, I'm just going to briefly outline what is a diagnostic accuracy study. So a diagnostic accuracy study evaluates the ability of one or more medical tests to correctly classify participants as having a target condition. Now, the target condition can be anything, can be disease, can be the stage of a disease, can be response or benefit of treatment, or even to predict a disease in the future. And the test can also be anything. It doesn't have to be just a laboratory test. It can be a history. It can be a physical finding, like you can have TROB. TROB has a sensitivity around 60%, specificity of 70%. So it's just an examination finding. Or it can be a combination of multiple things. So like PCR, like CRP plus ProCal for predicting sepsis. Or literally any method of collecting an information. So a diagnostic test doesn't just have to be a lab test. Now, the key components of a study design, you have three things. One is the index test, or that is the new test that you're trying to evaluate. The second is a reference standard, or what is the gold standard. So you have to compare it against something. So say if it's a TB study, your gold standard would be a TB culture, like an MGIT. So you need a gold standard. That's your reference standard. And then, of course, you have the target condition. What are you trying to identify? So in a TB study, it would be TB. Or if it's a sepsis study, did ProCal predict sepsis? So that is the condition that you need to look at. So now when you look at appraisal tools, you have a Casp checklist and the Quadas 2 tool. So the Casp is a simple and it's a simpler checklist. And for a basic study, you can use the Casp checklist. The Quadas 2 tool is actually for a systematic review meta-analysis of a diagnostic study. It looks at the risk of bias. And this is what we'll be looking at next week. You also have a STAR-D checklist, which is basically reporting guidelines. So when you have a study, when the authors are publishing it, they need to make sure all the aspects of the STAR-D checklist are there. It's already been done as a CU presentation. I'll just be briefly touching on it. So now finally coming to the study. So this is a diagnostic accuracy study of a point-of-care cardiac ultrasound for acute coronary syndromes in patients presenting to the chest pain to the emergency department. This is a single-center prospective study done in Italy. It was recently published in February 2025. So before we start, I have two case scenarios, which we will be coming back to in the end. But one is a 55-year-old gentleman with history of diabetes, hypertension, chronic smoker, presenting to the ED with retrosternal chest pain for 1 hour. But he also has some URI symptoms a few days prior. ECG, no STT changes. Troponin is awaited. The second one is a 45-year-old lady with no comorbidities. She's having some chest pain when she coughs or when she walks to the bathroom. Retrosternal has been there for the last 2 days. ECG, some non-specific STT changes. The first set of troponin is slightly elevated. What will you do? So now when we go through the Casp questionnaire, it has divided into 3 sections. The first section is, are the results of the study valid? So you're looking at the internal validity of the study. So the first question is, did the study address a clearly focused question? So yes, so they had all adult patients presenting to the ED with non-traumatic chest pain. The index test was a focused ultrasound done by the ED consultant looking for regional wall motion abnormality. The reference standard, I will come to it, but basically it was an adjudicated diagnosis of NSTEMI after 30 days on follow-up. The target condition was NSTEMI. So I gave this question a yes. So exclusion criteria, so they excluded patients who had ST elevation MI. They excluded patients who had cardiogenic shock or cardiac arrest, life-threatening ventricular arrhythmias. There was also trauma, as mentioned, was initially an exclusion criteria, and no consent. I think this is appropriate because if someone has an ST elevation MI, they automatically would be transferred under cardiology. So it seems to be a reasonable exclusion criteria. And this is the starred D checklist. I'm not going through it, but they had actually fulfilled all of this as well. The second question is, was there a comparison with an appropriate reference standard? So here, the reference standard they looked at is at the end of 30 days. So after the patient got discharged, a third or an independent ED physician looked at the review, looked at ECG, STROPS, and final discharge diagnosis, and then decided if the patient had NSTEMI or not. I feel like you didn't specifically need that because if there were two sets of enzymes that were elevated, or if the discharge, at the time of discharge, the discharging physicians, if they thought the patient had NSTEMI, it should have been NSTEMI, taken as NSTEMI. But so I felt there was some concern, but overall, yes, it was a reasonably good reference standard. Now, did all the patients get the diagnostic test and the reference standard? The one issue was there was no flow diagram. So how the patients came in. So how many patients came in to the ED, how many had ST elevation, therefore were excluded, how many were trauma, then how many underwent the test, and how many were lost to follow-up. Say, for example, in our ED, someone came with chest pain. The first set of drops was slightly elevated, but they said they don't want to wait and they go DAMA. That's also something that should have been captured and presented that they did not do. But all the 686 patients that they recruited did get an ultrasound done. They all had troponins and ECG. And they mentioned that the good ultrasound window was only present in 94.4%. But they did not exclude those with the poor window. So there's a 2x2 table which I've created with the data they had. And all the patients were included in it. So I said yes. So all the patients did get the diagnostic test and the reference standard. Now, could the results of the test have been influenced by the results of the reference standard? So, because technically the reference standard was at the end of 30 days, theoretically it shouldn't affect it. But an important point was the focus operator, that means the person doing the ultrasound, were not blinded to the first ECG or history. So, for example, I'm doing the ultrasound. Someone comes to me with old MI having severe chest pain for the last half an hour. I already think that this patient likely hasn't. So it's possible that my ultrasound is going to be biased. So ideally it's a yes, but because the reference standard was a composite outcome at 30, I've put it as can't tell, but likely yes. The next question is the disease status of the tested population clearly described? So the hint is you need to look at presenting complaints, disease or stage or severity, comorbidities, and the differentials. So that I gave it a yes because they've clearly defined what the population was, presenting to ED with chest pain, non-traumatic. They have excluded ST elevation, MI, cardiogenic shock, as we mentioned, but that seems reasonable. Otherwise, all patients were included, even with previous history of coronary artery disease or documented regional wall motion abnormality. They have given the comorbidities in the baseline characteristics. The differential diagnosis, they have not given it as a table, but they have just mentioned in the text that the non-cardiac was around 70%, non-coronary cardiac, so that is like heart failure without it being an MI, were around 13%, and NSTEMIs were 15.5%. So this is their baseline characteristics. Just to highlight that the median age was around 58. Reasonable mix of male and female, but males were slightly more. As always in all our studies, the diabetic patients were only 11%, whereas in our population, we'd expect a much higher number of it. Otherwise, I felt the things were all reasonable, what we would also expect to see. This I'm not going through, but it's again the ECGs of all the patients and the ECS algorithm. So that is what they use. As I said, this is done in Italy. So they looked at the highly sensitive troponin admission. That was their standard of care. So if it was very high, it would be a rule in yes and STEMI. If it was in between, you go into an observe group, or you could rule out based on the ECS algorithm. So were the methods of performing the test described in sufficient detail? So yes, they actually described it quite well. So The focus was performed at first presentation after the ECG because they wanted to rule out ST elevation MI, but before the troponin results came. The operators were supposed to be the ED physicians trained and certified in focus, but actually in the results, actually majority were performed by them, but 17.5 were done by residents and interns. So that is a slight deviation from protocol. They gave a standardized focus protocol, which almost all the classic windows were included. And the ultrasound machine is routinely available in their ED. So overall, yes, some concern because there was this small percentage which was done by interns and registrars. This is again the study checklist. Most of it was, yes, they had looked at. Here it is a regional wall motion abnormality, yes, no. But sometimes it can be a continuous outcome. So troponin levels of 10, 11, 12, 13, 14. So you might take a cutoff saying above this is high, above this is low. So that was not relevant in this study, therefore, they have not done it. So that was about how the study was conducted, internal validity. There were some concerns, but overall, I felt it was a well done study. So then you look at the results. So you, only if a study has been well done, then you go on to the results section. So here everyone's going to have to take out their pens and papers. We're going to do some maths. So what are the results? So you need to look at sensitivity, specificity, likelihood ratios, was it presented? So now I have created a 2x2 table with the information that they've given. So this column is patients who have NSTEMI. This column is no NSTEMI. This is the test positive. So regional wall motion abnormality present, regional wall motion abnormality not present. So this group, so that means NSTEMI is there and the test was positive, is true positive. This group where there's no NSTEMI, but the test was positive. So it's falsely positive. In this group, the disease is present, but the test was negative. So it's falsely negative. And here you have no NSTEMI, test also negative. So that is your true negative group. So these are important points because subsequently in each of these things, we'll be discussing it. Okay. So in any diagnostic study, some of the important measures are sensitivity, specificity, positive predictive value, negative predictive value, positive likelihood ratio, negative likelihood ratio, area under the curve, which I'll come to later. And I'll just briefly touch upon it. So sensitivity is the power to detect a disease. So a proportion of patients with the target condition who test positive. So a sensitive test is actually a screening tool. So one thing to remember is SNOUT. So sensitivity helps you rule out a disease. Okay. So the calculation for sensitivity is true positives divided by all patients with the disease. So in all, you have 100 patients with disease. How many of them tested positive is what sensitivity looks at. So you actually want a highly sensitive test as a screening tool. So say everyone is coming with, so the classic example is HIV, where you do an ELISA. So there's a possibility that some patients might be falsely positive, but that's okay. You're not missing anyone out. You can then do a confirmatory test. So you want a highly sensitive test for screening. So it's a rule out, so SNOUT. Okay, so this is the formula, true positive divided by true positive plus false negative. So everybody can calculate the sensitivity for our study. That is true positive divided by true positive plus false negative. That means test positive among all those with disease. Yeah, this is what everyone got. And this is what the authors got as well.
45 by 100.
Yeah. And they've given you a confidence interval as well. What is specificity? So confirming the absence of disease. So it's a spin. So spin is a mnemonic. So specificity rules in the disease. So a highly specific test means the disease is there. So it's actually defined as the test's ability to correctly identify patients without the disease. It's a probability of a negative test result when disease is truly absent. So that means among all the patients who don't have the disease, how many were test negative? So this is the formula. So test negative, true negative divided by true negative plus false positives. So true negatives divided by all patients without the disease. All right. Everyone can calculate. So that is true negative by everyone without the disease. Yeah?
538 by 58.
Yes, by the true negative by everyone without the disease. So the authors also got the same thing. Now you come to something called the positive predict value. Or it's sort of like the precision of a test or the clinical confidence of a test. So here it reflects how trustworthy and reliable a test truly is. So remember in sensitivity, true positive divided by everyone with the disease. Whereas here it's true positive divided by everyone with the test coming positive. So that is true positive divided by true positive and false positive. So the denominator here is true only related to the test. So true positive divided true positive by false positive. So So true positive divided by everyone who tested positive.
45 by 87.
Yes, 45 by 87. Yeah. Authors also got the same thing, but they've given us 95% confidence interval. What is negative predictive value? So negative predictive value, that the probability that a patient with the negative test result truly does not have the disease. So that means true negatives divided by everyone whose test is negative. So specificity is true negative by divided by everyone without the disease. Here it's true negative divided by everyone who who tests negative. So that will be this true negative divided by everyone who tests negative. Yeah.
538 by 599.
This true negative divided by everyone who tested negative. Okay. So now, but there's a problem with your positive and negative predictive value. So sensitivity, specificity are intrinsic tests of the these things of the test. So for example, whatever you do, the sensitivity and specificity does not change. But your positive predictive value and negative predictive value depends on the prevalence of the disease. So in this study, the NSTEMI prevalence was around 15%. Okay, so now say this was a chest pain unit, like exclusively patients coming with chest pain. In that case, I have randomly said, say NSTEMI prevalence was 40%. Now I've given you a different 2 by 2 table. So can we all calculate sensitivity again? You remember sensitivity formula? True positive divided by disease, everyone who's disease positive. Okay, 41.3, 42, my error, 41.3. Specificity, if you calculate true negative divided by everyone who is truly disease negative. Okay. So is it the same as our previous sensitivity specificity? All right. But now calculate your positive predictive value. That is true positive divided by everyone who's 79.4. So what was the previous positive predictive value? 50, right? So it's changed. So your sensitivity and specificity stayed the same, but your positive predictive value has changed. What about negative predictive value? So again, your values change based on prevalence. So you can only interpret a positive predictive value, negative predictive value for that particular study or that particular population because it keeps changing based on prevalence. Any number that you take, actually, I was also curious. So actually, calculators saying only 1%, it still works out to be the same. So your prevalence does matter. Even if it's specificity of 99%, that 1% itself will make a difference to your positive and negative predictive value. So then comes in something called likelihood ratios. So it combines sensitivity and specificity, and it does not depend on the baseline prevalence of the disease. And it's actually the most clinically relevant and applicable parameter from a clinician point of view. But it's a bit harder to calculate. Therefore, it's not. And I think FDA and all still looks at positive predictive value, negative predictive value. And the STAR-D checklist also looks at that. So authors are always reporting it. But the Casp checklist actually asks for likelihood ratios. So now, a positive likelihood ratio is how much more likely is a positive test result to occur in someone with the disease. So if a test is positive in someone with NSTEMI, like how much more likely is the NSTEMI diagnosis with a positive test? So the calculation is sensitivity divided by 1 minus specificity. Can we calculate that? I think 42.3 is sensitivity, 1 minus 92.7. $58, someone said. Yeah, so 5.8, you calculate. So the positive likelihood ratio here is 5.8. So that means a regional wall motion abnormality makes it 5.8 times more likely that a patient has a NSTEMI. Now, as a rule of thumb for likelihood ratios, if a likelihood ratio is greater than 10, that's a very strong evidence to suggest this patient probably has a disease. 5 to 8 is moderate, and less than that is not so great. Here we have a 5.8, which is just above that point. So there's a moderate likelihood that this test being positive increases the chances of patient having a disease. Then you have a negative likelihood ratio. So it's a probability of testing negative in someone with disease compared to probability of testing some negative in someone without the disease. So the calculation is 1 minus sensitivity divided by specificity.
And 58,
92.7.
Instead of 1, you should put 100.
No, otherwise you'll have to divide by
9. Maybe the decimal.
Yeah. So rule of thumb for negative likelihood ratio is only if it's less than 0.1 is there a strong quality of evidence. Here it's just above 0.5. So it's actually very weak or almost no likelihood, negative likelihood ratio. Now, but how do you actually use this likelihood ratio in a clinical setting? So that is something called you use something called a Fagan's normogram. Okay. So here you need sorry, it's a bit blurry. So you need a pre-test probability, right? So I think the patient has maybe 10% pre-test probability of having a disease. Now, if you have a positive likelihood ratio of 5.8, sorry, this is very. So you would draw a line from 10, the pre-test probability, across 5.8, and it gives you a post-test probability. So it's almost 40%. So from your 10% pre-test probability, this test makes it 40% more likely that this patient has disease, would be how you would apply this. Now I'll come to this a little bit later, but I just want to tell you about this thing called Fagan's normogram. Now, this I'm not really going to go into detail because, like I said, sensitivity specificity comes in when the test is test positive, test negative. So it's a dichotomous outcome. But sometimes the test might be, say, troponin levels. So troponin levels, it can be 0, 1, 2, 3, 4. It is a continuous outcome. So when you have something called a continuous outcome, you can either do above this level is positive, below this level is positive, or you can do something called a receiver operating characteristic curve or the ROC curve, where you have sensitivity on this side, on the y-axis, and 1 minus specificity. So you sort of like draw different points. For each value, what is the sensitivity, specificity? And you calculate the area under the curve. So if the area under the curve is high, so that means the test like higher up here, more area, then the test is better. So more than like 0.5 means it's the same, neither the test is not helping differentiate at all. More the area, better the diagnostic ability of the test. But it's not relevant in this case because it was regional wall motion plus negative. So it was a dichotomous outcome. So then you look at sensitivity, specificity, positive predictive values, and likelihood ratios. So now how sure are we about the results? Consequences and costs of alternatives performed. So we need to look at confidence interval. Yes, they gave you sensitivity, specificity, positive predictive value, negative predictive. All of them had confidence interval. The confidence interval was a bit wide in sensitivity, and anyway, it was only 42. It was not a great test. But again, there was no details on the loss to follow up, and they didn't do a formal cost analysis was not done. So again, this is the study. So they did not give you a flow diagram, and the distribution of severity per se they didn't mention, but all the other things were reasonably well explained, and they've given you precision. They didn't mention if there was any adverse effects. Specifically, they didn't mention it, but I mean, we're not really anticipating adverse effect from someone having a focus done. So now, the most important part of a study that you're interpreting, we want to know whether we can apply this locally, right? So will the test results help locally? So can the results be applied to your patients, the population of interest? So now here we need to look at our baseline characteristics and see, would this be similar to what we would get? Again, this was a single center study done in Italy. So yes, it was not like a multi-center trial. But as such, in terms of will we get patients with chest pain to our ED? Yes. So I think that's a good starting point. And the risk factors are also seem kind of similar to what we would get, except maybe diabetes would be much higher in our population. And in STEMI, that's a relevant point because it would increase your baseline prevalence. Can the test be applied to your patient or population of interest? So can we actually do it? We know that the patients might be similar, but can we do this? So yes, an ultrasound is available in our ED. We can't. So one thing is it requires some training. There is a bit of a learning curve, but we could train our ED consultants and medicine registrars to do it. Or actually, we anyway call the cardiologist. And I think anyway, our cardiologists are doing a ultrasound as well. So it can be done, but maybe there's a bit of a learning curve if it's not. So were all outcomes important to individual or population considered? So yes, they have given you sensitivity, specificity. That is what, as the clinician, we would want. They didn't give us likelihood ratios, but we can calculate it ourselves from the data that they've given. Now, they could have looked at like time to definitive diagnosis or time to hand over to cardiology. That might be something we're also interested in the ED, but they had done something else. So this is a alluvial plot. Okay. So it's a newer sort of like diagrammatic representation of what happened to the patients. So here they've looked at all patients. They've also done a subgroup on patients with type 1 MI. That means not like truly occlusive MIs they've looked at. So here they've divided based on the ECS triage group. So based on the troponin, the rule in, observe zone, or the rule out. And they've now added the focus to it, and they saw whether the patients moved. Okay, so this is integrated triages with the focus. So red is NSTEMI. So these many patients were in the rule out group. Of them, this small percentage had a NSTEMI, but they, based on the focus, some of them went from rule out, where they were just waiting for repeat drop. They went into the observe, and a small percentage went into the rule in. That's very nice. Okay. Yeah, that's good. Yeah. Okay. So it basically, this is a rule out. So in the ECS triage group is rule out, observe, rule in. Whereas in the integrated triage, that means where you're including focus, you either just have a rule in or a rule out group. And this shows how the patient, like the flow of the patient diagram. So regional wall motion abnormality, yes. So these patients then went into the rule in category. So basically, they're just saying that some people who were, as per the ECS, originally kept as rule out or observe, if they had a positive test on the ultrasound, they've changed into a rule in category. Now, they've also given you something called this is new, it's the net recalcification improvement. So basically, it's whether the model improves decision making. So that's what the alluvial plot sort of gave you as a pictorial representation. This they're giving it to you as a index or a how much the new test improved your previous test. So now you have the old model, which uses troponin and ECG. New model, in this particular case, we've added focus. So now you want to see how many patients were reclassified, whether they moved up or down in the prediction index. So now this is their results. So the total NRI was improved by 57%. So there was some improvement. But when they looked at events and no events, so in the NSTEMI present group, it was actually quite a bad NRI. That means some patients who actually would have gone into a observed category, they downgraded them to no NSTEMI based on the regional wall motion abnormality. But in the no ST elevation group, no NSTEMI group, it had a good value. But that's sort of different from the positive predictive value and the sensitivity. So you have to sort of interpret all these parameters in your setting. So now what would be the impact of using this test on your patient or your population? So now we're coming back to our case scenarios, right? So now a 55-year-old male with multiple risk factors of MI presented with retrosternal chest pain for half an hour. Your TROPs are awaited. Okay, now baseline, what do you guys think is your pre-test probability of this patient having an MI? 70%. Okay, sure. So it's maybe high, maybe 70%, then you should go ahead and treat anyway. You shouldn't be doing any test. But say it's 40% or something like that, then you want to do additional tests. Now here there's a regional wall motion abnormality. Just based on that information alone, as clinicians who are seeing this, what do you think it goes up by? Say if it was 70, now what is your 90? For 40? Yeah, so even without anything, we as clinicians, based on what we know, would want to go up on that. So what about case scenario 2? 45-year-old lady, no comorbidities, having some chest pain, cough when she coughs or when she moves. It's been there for the last 2 days. ECG, some non-specific changes. Troponins are mildly elevated. So according to the ECS protocol, she'd be in the observe category. So what is your pretest probability here? What do you guys think? 10%? Okay, maybe. Now the focus is showing no regional wall motion abnormality. So you'll send her home saying no elevation, or you'll still repeat? Okay, so this is the question that we are actually faced with. So now can we apply this test to our scenario is the question. So here I'm going to come back to that nomogram. So ideally, we actually need to change this into a probable, like a odds, but we leave it at that. So we'll say, what is your pretest? So Vineet said 40 for the patient, right? And we had a 5.6 positive likelihood ratio. So from 40, it goes up to, okay, I'm sorry, the pointer is a bit funny, but yeah, almost 70 to 80% is your probability. So here you could potentially call cardio right away or like start treatment for NSTEMI because it seems like it's a NSTEMI, right? Now in the second one, we think our pretest probability is low to begin with. So what did we say? You said 10. So 10, and we said the negative ratio was 0.62. So let's go from 10 to, okay, this is very, yeah, so from 10 to 0.62. but it's only reducing it by, from 10, it went to 5. So anyway, your pretest probability was only 10. You only brought it down to 5. So can you truly say this patient has no NSTEMI? Not based on this test. And baseline also, as clinicians, we're not going to be like, okay, go home. We would probably still wait. So that is kind of how a likelihood ratio helps you. So like sensitivity, specificity is sometimes hard to interpret, but you can use the likelihood ratios to incorporate that into your clinical setting and your risk factors. So here the prevalence and all don't matter because you're incorporating your pretest probability based on your baseline knowledge. Okay. So I'd like to acknowledge Dr. THAMBU and Dr. Vignesh. Any questions?